Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Menopause and Hormone Replacement Therapy, presented by Dr. Jaya Kediyal, Family Medicine with Washington Township Medical Foundation. Dr. Kediyal is board certified in family medicine. She chose family medicine because she enjoys forging long-term partnerships with her patients. Another aspect of family medicine that Dr. Kediyal appreciates is the opportunity of meeting and providing health care to a wide range of ages, oftentimes entire families. Dr. Kediyal's philosophy of care is to treat the whole person, their body, mind, and spirit. Please welcome Dr. Kediyal.
Hello everyone, I'm Dr. Jaya Kediyal, board certified family physician, and today we'll be talking about menopause and hormone replacement therapy. So what is menopause? We clinically diagnose women with menopause when they have had 12 months of no menstrual cycles, vaginal bleeding, or spotting. You stop having your menstrual cycles permanently, you can no longer get pregnant, and basically your ovaries are not producing eggs anymore. So your reproductive years are over. Age range for menopause can be anywhere from 40 years to 58 years, and the average age being 51 years. What is perimenopause? Perimenopause is pretty much the years leading up to your menopause, also known as premenopause, and the symptoms during the menopause and premenopause and perimenopause can all be same. People can experience the same symptoms. It's basically a slow transition to menopause, and women can have varied symptoms during this phase. Some women can have skipped periods, some women can experience irregular periods, some women can experience heavier periods, and some might just say that they are having scantier periods. But what we have generally seen is that women, as they come closer to menopause, their menstrual cycles are farther apart. What are the causes of menopause? For most healthy women, the cause for menopause is natural. The ovaries over time stop making hormones, estrogen and progesterone. For some women, it could be surgeries. Oophorectomy, which is removal of your both ovaries, would cause instant menopause because you're no longer producing hormones, which are basically progesterone and estrogen. So you cannot have menstrual cycles. The other surgery that can cause menopause is hysterectomy, where women for certain conditions have to get their uterus removed, and they cannot have menstrual cycle either. But in this case, the menopause is not as instant because you still have your ovaries and they're still producing hormones for some time. What we call next menopause is medical menopause, where women have radiation and chemotherapy. Whole body radiation and radiation targeting lower spine and pelvis can often lead to menopause, and some chemotherapies which are targeted for certain cancers can lead to transient or permanent menopause symptoms in some women. And last but not the least is primary ovarian insufficiency, where women have menopause before age 40. This could be genetics. Sometimes there's no clear reasons, and in some women we have found that there are underlying autoimmune disease. When you are going through menopausal or perimenopausal symptoms before 40, it's a good idea to talk to your doctor. Because there are some very common conditions which can mimic perimenopausal symptoms, like that would be thyroid dysregulation or severe anemia. So if you feel like you are having perimenopausal symptoms way before the expected age, then talk to your doctor about it promptly. What are the symptoms of menopause? The symptoms of menopause can vary from woman to woman, person to person, and there's no one experience. But we have seen that vasomotor symptoms, which is basically popularly called hot flashes and night sweats, approximately 50 to 80% of women experience it. It can be very disabling, and depending on the severity, can severely affect the quality of life of a person. And just imagine somebody trying to attend a Zoom meeting for his office and is experiencing hot flashes 7 times a day, and as they're trying to attend that meeting, they're drenching. So these symptoms and their intensity is variable. But we have seen some interesting facts that there are risk factors and triggers. Some women do experience more vasomotor symptoms because they have certain risk factors, which would include smoking, higher alcohol intake, obesity, lack of exercise, and history of depression and anxiety. Next would be genitourinary symptoms, where women who are perimenopausal or menopausal experience vaginal dryness, irritation, pain during sex, sexual discomfort, and because they have urethral inflammation and swelling and dryness, sometimes they can also have recurrent urinary tract infections, which can get really bad if not detected on time. Mood changes, we all have heard a lot about it. Yes, women can have what popularly is called mood swings or mood changes when they're going through the hormonal transition. But what I would like to point out here is that you are not going to have your first episode of depression while you're on menopause. So menopause does not cause depression. If you have history of depression or anxiety or some other mental health illness, then that can flare up during your menopause years or perimenopausal years. That we have seen. The other very commonly reported symptoms are fatigue, brain fog, memory changes, sleep disturbances, and low libido. So what are the body changes or physiological changes women experience with menopause? When estrogen levels decline, it brings physiological changes in your body. Heart and circulatory diseases, we see that the women who are post-menopausal are higher risk of cardiovascular diseases. Now this can be a combination of menopause and lower estrogen and aging process together, but we see that women will say, oh well, I always had family history of blood pressure and cholesterol or high sugar and diabetes, but I was always able to manage it through my lifestyle. But now my cholesterol is shooting up, my blood pressure is shooting up, or I'm doing the same things, but I'm becoming more diabetic. So that is what I would say, that some women who already have genetic history, the menopause with low estrogen can actually potentiate it. We have seen at approximately 2.5 times more cardiovascular events in women which are postmenopausal compared to premenopausal. Bone density loss, as the estrogen levels decline, we also see low bone density in women, and so this can lead to osteoporosis as women age. Decreased bladder control is very common. Sexual changes, obviously, like I mentioned before, low libido, discomfort during sex. Weight gain, hormonal decline, basically when estrogen goes down, it leads to fat redistribution. We don't have the same kind of hormones that we used to have, and as we are aging, we are losing muscle mass. So muscle mass usually requires more calories from the body. It requires body to burn more calories. When we start losing muscle mass and we have low estrogen, what ends up happening is there's fat redistribution. Women often say that, oh, I am just suddenly having a disproportionate weight gain around my abdomen, which is commonly noticed after menopause. So now we have discussed what menopause is, what are the common symptoms are, and what are the physiological changes associated with menopause is. And now we'll go to an important topic, which is what is hormonal replacement therapy. Hormonal replacement therapy is basically medical treatment for your symptoms of perimenopause and menopause. There are two ways to do this. One is estrogen only, where estrogen only is not the most predominant method to consider hormone replacement therapy, which now I will call HRT, because it predisposes women to uterine cancer or endometrial or uterus cancer. It is considered sometimes for women who do not have uterus anymore. For some reason now they have had hysterectomy or uterus surgery. The most common way of HRT is combined, where you get both your hormones, estrogen and progesterone, together. Because it's a simple thing. Any woman with intact uterus needs progesterone in their hormonal replacement therapy. Why? Because progesterone protects uterus. Usually recommended duration for combined HRT is 3 to 5 years, but obviously it can change from case to case basis, which your physician will consider, which your gynecologist can consider based on how severe your symptoms are and what your risk factors are. So what are the routes of administration of HRT? The most common route of HRT administration is what we call systemic. Systemic meaning you use an oral pill, just like you use your oral contraceptive pill, which has hormone combination. And the other routes would be transdermal through patches, gels, and sprays. The systemic HRT goes into your bloodstream, and then it also reaches all the organs. The local HRT would be where we are just targeting the genitourinary symptoms more, where you are just mostly not having severe vasomotor symptoms or other severe symptoms, and we are only concerned about genitourinary symptoms, where your doctor can prescribe you a vaginal estrogen formulation, and that helps considerably. This type of local HRT does not go to your bloodstream and does not have similar risks. Very interestingly, over-the-counter vaginal moisturizers like Reverie and Repellents have shown to have the same effect in decreasing vaginal dryness and irritation as vaginal estrogens. They have controlled pH, so they are somewhat safer than using natural oils. So now we'll discuss what are the benefits versus risks of HRT. The benefit of HRT is that it is the most effective therapy for vasomotor symptoms, or basically hot flashes and night sweats. Women experience almost 80% to 100% relief. It also improves their moods and sleep disturbances and fatigue. It also relieves significantly vaginal dryness, discomfort, and sexual discomfort as well. It maintains bone density, so lower risks of developing osteoporosis. Combined HRT may reduce risk of colon cancer in some people. In women who are younger, in the sense that they're still in their 40s or age less than 60, and who are started on HRT within 10 years of their menopause, might experience less heart attacks. What are the risks of HRT? Estrogen-only HRT increases risk of uterus cancer. Combined HRT, which is usually the primary way for any woman who has intact uterus, increases risk of breast cancer. Higher risk of cardiovascular diseases are seen in women who are using HRT above age 60. So we have seen 1 out of 165 women using HRT experiencing a stroke, a deep vein thrombosis or DVT, popularly known as DVT. 1 out of 118 women in the study showed they had DVT who were using HRT, and then 1 out of 242 women experienced a pulmonary embolism, which is basically a clot in your lung and can be very fatal. There is also noted that there's higher risk of developing dementia and gallbladder disease in women through HRT. So since just like any other medication, HRT has risks associated, which we just went through. The question is, who are the candidates for a hormonal replacement therapy? Women who are experiencing moderate to severe symptoms, where it is affecting their quality of life severely enough, should be considered for HRT. So these would be women who do not have major risk factors, like they do not have history of breast cancer, uterus cancer, history of stroke, history of blood clots, certain other factors like BMI greater than 35, liver disease, and you cannot be pregnant when you are considering HRT. Women with early menopause, where they have menopause before 40 years, are also great candidate for HRT because they are at a higher risk of bone density loss and cardiovascular diseases. So it is advised that we consider HRT for women with primary ovarian failure, so that we can reduce their risk of developing these conditions up to mean age of menopause. What is effective approach to HRT? So a balanced approach to HRT would be lowest dose for shortest duration. Just think about it same as how you use your antibiotics. If there's an antibiotic that you can use for 7 days for the same infection versus 14 days, and if all your symptoms are resolved in 7 days, why would you take 7 extra days of that same medicine? Exactly the same logic here. If your symptoms are primarily going away, fading away as you're advancing postmenopausal, then you do not want to be on a hormonal replacement therapy. So the basic idea is lowest dose and shortest effective duration. So generally 3 years to 5 years is considered a good duration to be on HRT. After that, it does increase risk of breast cancer in women. Transdermal patches, gel sprays and rings are slightly less riskier than oral HRT pills. So they should be considered for women who could be higher risk, like if you have a BMI which is above 30 and you have strong family history of blood clots, then that would be important to consider and you're having severe symptoms and you really want to be on HRT, then you might think more about the transdermal options. The local and vaginal hormone, the good news is that studies show that local vaginal estrogen does not increase the risk of cardiovascular diseases or any kind of cancers. And it does, and it's local, so it does effectively help your symptoms. Since we're talking about HRT, we'll also cover briefly about bioidentical hormones. Bioidentical hormones are basically specially compounded in the certain pharmacies, made to the order by certain physicians by these pharmacies. These hormones are almost identical to human hormones, but they are not FDA approved. A lot of them are not FDA approved, and if you're actually considering bioidentical hormones, then it's best to consider the ones that are FDA approved. Also, it's important to know there's no benefit over HRT. Like using bioidentical hormones does not render you any benefits over your standard of care, which is HRT, which you can talk to your physician about. So there will be women who will be experiencing the symptoms of menopause and perimenopause, but they might say that I don't want to do the hormonal therapy, or they simply might not be good candidates for hormonal therapy. So what are there options for those women? Yes, we have antidepressant and anti-anxiety medications, especially some medications like Lexapro and Effexor. They are very effective with hot flashes, mood swings and sleep disturbances, and they're reasonable alternatives. While they might not be as effective as hormonal replacement therapy, they provide reasonable relief to most women. Gabapentin is an anti-seizure medication. It also reduces hot flashes, decreases mood changes, and decreased sleep disturbances, and it's a relatively milder therapy. Also, some patients can use clonidine, which is popularly known blood pressure medication. It decreases blood pressure, so and it decreases hot flashes. So that is some medicine that can be considered for women who already have high blood pressure. The medicine also comes in transdermal form. Again, it is not as effective as HRT, but it's definitely an option for you. And then there is a new medication called Veozah. It works on brain pathways to decrease hot flashes, and it's a newer medication, so it's also another non-hormonal option for you. A very important question, because a lot of my patients ask this all the time: can I take something natural for my menopausal and perimenopausal symptoms? So what I would like to tell you is that data does not support that soy, flax, berries, wine, ginseng, or black cohosh substantially help vasomotor or menopausal symptoms. The data does not support that there is actual relief. And in fact, in some studies it was shown that black cohosh in women who have underlying risk factor, there can be liver toxicity. So you have to be careful with that. What we have found though, that lavender and vitamin D supplements and lavender use can help women with flushing and improve sleep. So maybe lean more towards that. So what are the lifestyle changes for menopausal and postmenopausal women? Like we previously discussed how your body changes, I would say a lot of things for healthy lifestyles continue, but there are a few things that we can be a little bit more careful when we are in our perimenopausal, menopause or postmenopausal years in our life. The diet needs to be balanced. Now, as we are aging and now that we have lower estrogen in our diet, we are more prone to cardiovascular diseases. If you already have history of diabetes, high cholesterol, high blood pressure in your family, then you should consider high fiber diet, which is a lot more plant-based diet. So 2.5 cups of vegetables, 1.5 cup of fruits, approximately 3 cup of low-fat milk products, and considering 5 to 6 ounces of whole grains, which includes your wheat, oat, barley, millet, quinoa. All legumes, or popularly known as legumes and lentils, are great source of high fiber and good protein, and they're also complex carb. You can continue to have your healthy lean meat servings, about 5 ounces a day, and consider fish, fatty fishes like tuna, because they are better for your cardiovascular health. As we have lower estrogen, we are also seeing decreasing bone density. So what can we do to maintain our bone density when it comes to our diet? Consider approximately 1,000 to 1,200 milligram of calcium and 800 to 1,000 units, international units of vitamin D3 for bone health. I do not like that that we get all our calcium and vitamin D from supplements. Consider including a lot more foods which are rich in calcium and vitamin D in your diet whenever possible, and then do some consistent supplementation along with that. Other thing I would say is that if you're already overweight and you're trying to avoid obesity, or you already have a BMI of 30 and excess weight, then consider intermittent fasting, because the metabolic rate goes down as the estrogen goes down and as we age. So consider intermittent fasting if you can, if it works for you. 16:8 ratio, where you are not eating anything for 16 hours, and then consider 2 balanced meals in those 8 hours duration. And I would say keep it sustainable. If there is a day that you cannot be absolutely on a 2-meal diet, have your 3rd meal or consider a healthy snack. So basically the idea is to not put excess calorie or same amount of calories that you were using, especially if your lifestyle is sedentary or when you're not picking up any exercise, because now you will start gaining weight in a very different fashion. I would also urge to consider a diet which is low in processed meats, foods, sugar, caffeine, and consider more home-cooked food. Avoid excess alcohol. In general, menopausal and postmenopausal symptoms do not go along well with alcohol intake. In fact, alcohol and caffeine are known triggers that worsen your menopausal symptoms. So consider limiting your drink to maximum 1 drink per day, and if you can go lower, it's even better. Regular exercise, 30 to 45 minutes, even 4 days a week is great. Try to mix different activities. Try to do some high impact activities and then low impact activities. And if you don't feel like at all, just go on a simple 45 minutes walk someday, and then add some jogging here and there. So the idea is to keep showing up for a better lifestyle after menopause, because your body will need more care, and the more care you take, the better it is, and the earlier you understand it, of course, the better it is. And this concludes my presentation, and this is my picture from my mom and this summer in India, Missouri, when I see her, I realize that aging is not just skin deep, right? So we all should believe in what Audrey Hepburn is saying, and the beauty of a woman with passing years only grows. Any questions?
Yes, thank you, Dr. Kediyal. We do have a couple of questions. The first is, should hormone replacement therapy be considered for prevention for cardiovascular disease?
So yeah, so it's very important and a very great, good question. We have to understand that there are a lot of misconceptions about hormonal replacement therapy. The idea is that, oh, if I take hormonal replacement therapy, I will not age and I will not get heart attacks or strokes. But that's not true. There, like I mentioned before, there were women, 1 out of 118 women which had deep vein thrombosis, 1 out of 242 women had pulmonary embolism. So this is not a good approach. We are still, the research on HRT use is still evolving, and like any other medication or therapy, it has its risks, so it's not a primary prevention method or therapy for cardiovascular diseases.
Okay, and our next and last question is, does going through hormone replacement therapy treatments mean less fracture risks as women age?
We would think that since our bone density with the use of hormonal replacement therapy is not declining at the rate where it would if we were not on hormonal replacement therapy, the fact is that using hormonal replacement therapy does not reduce your risk of fractures. There's no decrease in the incidence of fracture for women who were using hormonal replacement therapy as they aged. So if you have osteoporosis, then the treatment is osteoporosis medication, not hormonal replacement therapy. So because it will not reduce your risk of fractures, even though it maintains your bone density.
Okay, thank you, Dr. Kediyal, for this insightful presentation. This does conclude our program. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.